Good day, everyone. My name is Rosetta Onuh. I am a Doctor of Nursing practice student at Maryville University, and I'll be presenting my Quality Improvement DMP project. My topic is safe smoking policy and health-related quality of life among residents in a long-term nursing facility. Introduction. Cigarette smoke contains over 7,000 toxic chemicals that are potentially cancerous. Cigarette smoking has been associated with poor glycemic control, poor blood pressure control, and poor health outcome. There is a population of residents living in a long-term nursing facility that smoke and others who do not. While some residents smoke cigarettes in their rooms, others who do not smoke become secondary smokers due to the activities of those who smoke. So, creating a safe smoking policy may protect smokers and non smokers from harm related to tobacco exposure. This will also help smokers achieve a reduction in number of cigarette sticks consumed. The empirical evidence. There is an empirical evidence that safe smoking in designated area can potentially reduce cigarette smoking rate. For example, there is a study by Jaun in 2019 which states that temporary smoke-free public policy in Chengdu, China during the 2008 Summer Olympics was associated with long-term reduction in male smoking rates and a decline in secondhand smoke exposure rate. It is unknown to what extent a comprehensive safe smoking policy influences in the health-related quality among residents living in a long-term nursing facility. The aim of this quality improvement project, therefore, it was to assess the relationship between safe smoking policy and measures of health-related quality of life. Health-related quality of life that were measured in this project are the mean systolic blood pressure, mean diastolic blood pressure, hemoglobin A1C, and proportion of respiratory infection per month. This is checked every month. Method. This pre and post design assess the association between safe smoking policy and measures of health-related quality of life. The study population were residents living in a long-term nursing facility who smoke cigarettes. The data source were from the administrative data and electronic health record of the facility. The data extracted from December 2022 to June 2023, making it a period of 6 months. The safe smoking policy was started in March 2023. So all data selected from December 2022 to February 2023 represent 3 months prior to the policy intervention. And data from April 2023 to June 2023 represent 3 months after the policy intervention. The total residents identified as smokers from the administrative data record were 29 residents. predictor variables was the safe smoking policy. This variable is a temporal variable which measured before and after creation of the safe smoking policy. The outcome variable are four measures of health-related quality of life: the mean systolic blood pressure, the mean diastolic blood pressure, the mean hemoglobin A1C, and the proportion of respiratory infection. Systolic and diastolic blood pressure. Selected the systolic and diastolic blood pressure that were selected for this project were recorded values taken on the first day of each month. The hemoglobin A1C is done every 3 months, so the first hemoglobin A1C value for each patient were selected. The monthly rate of respiratory infection among study population were computed for each month in the pre-intervention and post-intervention phase. So for the pre-intervention period, I computed the means and standard variation of systolic and diastolic blood pressure between December 2022 and February 2023. And for the post-intervention period, I computed the mean and standard deviation of systolic and diastolic blood pressure between April 2023 and June 2023. I also computed the mean hemoglobin A1C before and after the policy creation, and I computed the proportion of respiratory infection before and after policy creation. The paired sample. The t-test was used to test the difference in the mean systolic and diastolic pressure, hemoglobin A1C before and after the policy creation. The one-sided z-test was used to test the difference in the proportion of respiratory infection before and after safe smoking policy creation. Table 1. Table 1 summarizes some of the demographic characteristics of study population. The mean age of the study population was 53 years old. The mean weight and height of this population was 216 kg and 56 meters respectively. The body mass index was 34.2 kg. The study population was predominantly non-Hispanic, Black, which accounted for 62% of the study population. The non-Hispanic whites and Hispanic population accounted for 17% and 21% respectively. The population in this project were predominantly male, and they accounted for 72% of the study population. In the 3 months prior to the creation of safe smoking policy, the mean monthly systolic blood pressure ranged from 189 millimeter per mercury to 191 millimeter per mercury. However, after the smoking policy was created, the mean monthly systolic blood pressure trended downwards. from 189 millimeter per mercury to 172 millimeter per mercury. The 3 months prior to the creation of the safe smoking policy, the mean monthly diastolic blood pressure ranged from 91 millimeter per mercury to 93 millimeter per mercury. However, after the smoking policy was created, the mean monthly diastolic blood pressure trended downwards as well from 93 millimeter per mercury to 87 millimeter per mercury. Within the 3 months prior to the creation of the safe smoking policy, the mean hemoglobin A1C was 14. And after the smoking policy was created, the mean hemoglobin A1C was lowered at a value of 12.4. The proportion of residents treated with respiratory infection in the first 3 months prior to the creation of safe smoking policy was 100%. After the creation of the smoking policy, residents treated for respiratory infection decreased to a 94%. Table 2. The mean reduction in systolic blood pressure after the creation of smoking policy was 11.3 millimeter per mercury. The observed reduction in the mean systolic blood pressure after the safe smoking intervention as compared to the mean systolic blood pressure before the intervention was significantly lowered. The diastolic blood pressure, the mean reduction in diastolic blood pressure after the creation of the smoking policy was 2.9 millimeter per mercury. The observed reduction in the mean diastolic blood pressure after the creation of smoking policy as compared to the mean diastolic blood pressure before the intervention was also significantly lowered. The mean reduction in hemoglobin A1C after the creation of safe smoking policy was 1.6. The observed reduction in the mean hemoglobin A1C after the creation of smoking policy as compared to mean hemoglobin A1C before the intervention was also significantly lowered. The proportion of respiratory infection. The difference in the two proportions was 19%, suggesting that the proportion of respiratory infection was higher before the intervention compared to after the intervention. The p-value of the observed difference was 0.013, which is statistically significant. In this quality improvement project, the safe smoking policy was associated with improved systolic and diastolic blood pressure, improved hemoglobin A1C, and reduced respiratory infection rate 3 months after the policy was created. An explanation of this finding is that the smoking policy might have a reduction in number of cigarettes smoked Under the safe smoking policy, all cigarettes smoked in the facility must be handed by a designated administrator. All cigarette smoking paraphernalia were kept by the designated administrator as well. Smoking the cigarettes were all smoked only at the scheduled time. Residents were not allowed to go out into the smoking environment, the smoking designated smoking area until the break time. Residents were also handed water as a source of hydration prior to them go as they are going out to the designated time to smoke instead of sodas. The scheduled break time, the cigarettes were only smoked at scheduled break time. This scheduled break time occurs 3 times in a day. The cigarettes that were smoked only in the designated open space outside the nursing home complex. So it is possible that these regulations reduce the overall quantity of cigarette stick that were consumed. And it also reduced the number of non healthy choice snacks that these patients were having because there is a decreased time that they were going out to smoke. Implementation for nursing practice. This study shows that implementation of safe smoking policy has demonstrated significant positive impact on health-related quality of life, including blood pressure, hemoglobin A1C level, and proportion of treated respiratory infection among residents living in a long-term nursing facility. So nurses, nurse practitioners, director of nursing, assistant director of nursing that works in the long-term nursing facility should have continued discussion about smoking cessation with residents who smoke and prioritize intervention at smoking cessation as well. Providers, nurses, and pharmacists should collaborate also to deliver effective smoking cessation intervention while considering both the physical and psychological aspect of nicotine addiction. And there should also be a continued enforcement of the smoking policy to new residents who are coming into the long-term facility. It is proposed as well to have residents and family members sign the policy to adhere to this policy while they are in the facility in order to help with reduction of secondhand smoking to residents who do not smoke. This study has some implication for future research as well as especially in the field of public health, epidemiology, clinical medicine. We have few studies in the United States conducting researches among residents living in long-term facilities. Clinical trials in long-term facilities. So this project provides insights into the potential benefits of conducting clinical trials among residents in long-term care facilities. Future studies can explore the long-term effects of safe smoking policy on blood pressure, hemoglobin A1C, respiratory infection, and also future studies can assess if a safe smoking policy will be associated with smoking cessation or reduction. Here are my references. I have Dove. This is extracted from a journal, Nicotine and Tobacco Research. I have Lowe's from American Journal of American Heart Association, SEER, Annals of Medicine. And I will take questions right now. Any question and comments are welcome. Thank you for your time.